Good evening, friends.
Good evening, all. Indian Medical College welcomes you all to this online class. In today's session, we have Dr. Amit Kumar Jain from Rashtriya Medical College with us. He's having plenty of teaching experience behind him. He'll be taking class on refractive errors today. Good evening and welcome, sir. It's a great pleasure to have you here with us, sir.
Thank you. Thanks for your kind words.
Dear viewers, dear viewers, the live chat session is enabled along with this live stream. If you have any doubts, please type them in the chat section or join with us via Zoom application using the meeting ID 270-999-3428. Your queries will be clarified by him at the end of the session. Sir, you can share your screen to start the presentation now. Thank you, sir.
Good evening, friends. Good evening, friends. Today, in continuation of my previous session regarding the optics of human eye, I'm going to talk on refractive errors. Practically, it is impossible to get an optical system foolproof so that all the rays, they should focus on one point. What we have discussed in the previous session, that when the cornea, the crystalline lens, they are all in alignment and the focus is formed on retina, then a person will see a clear image. But practically, there will be, even if there is a micrometer error in their alignment, then the focus formed is not clear and sharp to the person. So misalignment in the refraction is termed as refractive error. What are the refractive status of human eye? It could be emmetropic status or it could be ametropic status. So what is emmetropia? Emmetropia means no refractive error. It is the ideal condition in which all the incident parallel rays come to a perfect focus upon the light sensitive layer of the retina when accommodation is at rest. It means what? When all the rays, they come and focus on a single point, they form a clear and sharp image. So E is the image, E for elephant, E means no error. Emmetropia is, there is a refractive error of the eye. It is just opposite condition wherein all the parallel rays from the infinity or from an object is not focused exactly on the retina and form a clear and sharp image when the accommodation is at rest. So A for apple means absence of focus. That's how we have to remember. Because many times when the MCQ is asked, what is ametropia and emmetropia, there is a confusion whether E is normal or A is normal. A is abnormal. E is, there is no refractive error. That is normal. So what are the types of ametropia? When the rays are not focusing on the retina, either they can focus behind the retina or they can focus in front of retina, or few of them can focus in front or in behind or on retina. There will be combination. So when all the rays, they don't focus on retina and they focus behind the retina, that condition is called as hypermetropia. Hypermetropia, where the principal focus is formed behind the retina. So this we can see all the parallel rays, they are coming and they are just focusing behind the retina. Retina is little further away. So what are the conditions of, or what are the elements of refraction which causes principal focus not to be formed on retina? We will come to know that. So hypermetropia can be classified on the basis of either etiology, on the basis of clinical presentation, based on the degree of hypermetropia. So on this basis, we can classify this condition of hypermetropia where the principal focus is behind the retina. So based on the etiology, what are the types of hypermetropia? They are axial hypermetropia, curvatural hypermetropia, index hypermetropia, displacement hypermetropia, and aphakic hypermetropia. Similarly, on the basis of clinical presentation, it could be simple hypermetropia, it could be pathological hypermetropia, it could be functional hypermetropia. Based on the degree of hypermetropia, it could be mild, moderate, or severe. Mild is when the refractive error is plus 0.25 to plus 2 diopters. Moderate could be plus 2.25 diopters to plus 0.5 diopters. And severe is when the refractive error is more than plus 5 diopters. So we will see one by one what are these types of hypermetropia. We'll start with axial hypermetropia. Axial hypermetropia, many students, they feel that the eyeball is refractive power is reduced. No, the refractive power of the eyeball remains normal, but the axial length of eyeball is reduced. So there is decrease in the axial length, but the total refractive power of the eye remains normal. That's how the rays which are coming from infinity focuses behind the retina. Axial hypermetropia is far more the most commonest percentage refractive error seen throughout the world. All the newborns are almost invariably hypermetropic. They are hypermetropic from plus 2.5 to plus 3 diopters because the shortness of the globe and this hypermetropia is physiological. This is not a pathological condition. Why we will see in the further course how this hypermetropic status of a newborn gets converted into emmetropia. So just for this thing, refining the previous session, I have started the MCQ, but as per our suggestion, I will take this MCQ session at the end of this talk. So normal axial length of an eyeball is 24 millimeter to 24.5 millimeter. 1 millimeter decrease in axial length can induce up to plus 3 diopters of hypermetropia. So this is the condition of axial hypermetropia. When the accommodation is at rest, all the rays, they fall on behind the retina just because the axial length of the eyeball is shorter than the 24.5 or 24.4 millimeter length. Similarly, when we come to curvatural myopia, as the name suggests, curvatural myopia, there is changes in the curvature, in which the curvature of cornea or lens or both, either cornea or lens or both of them are flatter than the normal. When the curvature is flatter, the refractive power of the optical system decreases. When the curvature is steeper, the optical power of the optical system or refractive power of the optical system increases. So similarly, when these elements of refraction, either cornea or lens, their curvature become flatter. In that case, there will be curvatural hypermetropia. In these cases of curvatural hypermetropia, the length, the axial length of the eyeball is almost normal. Almost normal. Like in previous condition, the axial length was reduced. But in this condition, it is the curvature which is flat, but the axial length is almost normal. As we know from the previous session of optics, anterior surface of cornea is 7.8 millimeter, posterior surface of the cornea is 6.5 millimeter. These are the curvatures of cornea. 1 millimeter increase in radius of curvature will result in 6 diopter of hypermetropia. Here we have to remember that 1 millimeter of radius of curvature. Many a time in MCQ they just confuse because we forget by the time of internship that whether it is increase in radius of curvature or they can give 1 millimeter flattening of curvature. Flattening of curvature, it results in 6 diopter of hypermetropia. So this point we have to remember. See, this was again an MCQ which we will take in the later session. What was the radius of curvature of crystalline lens? Because cornea, I told you, crystalline lens we should remember. Again, the change in curvature of crystalline lens will cause the hypermetropia. What is index hypermetropia? Again, by the name, where there is change in the refractive index. The refractive index or index hypermetropia occurs due to change in the refractive index of the lens. Yes, because the refractive index of cornea, we remember all well, is homogeneous and it remains constant unless until it gets hydrated or there is some pathology induced. But in normal physiological condition, there is no change in the refractive index of cornea. But the refractive index of the lens changes with the age. So when there is old age, the refractive index of the lens changes. Normally, the normal crystalline lens, the refractive index of crystalline lens is 1.42. Any change will lead to index hypermetropia. Now, what is displacement hypermetropia? It is the fourth type of the, based on the classification of the etiology. Displacement, as the name says, positional. When there is a change in the position of crystalline lens. And the crystalline lens position should be changed in the backward direction. Once the crystalline lens goes towards the retina or moves towards the retina or towards the vitreous cavity, in this condition, there will be hypermetropia. And on contrary, when the lens moves towards the cornea or towards the anterior chamber, then there will be myopia. This movement of the lens in a condition called buphthalmos, usually the crystalline lens moves in the backward direction. What is aphakic hypermetropia? Aphakic hypermetropia could be because of absence of crystalline lens. That absence of crystalline lens may be because of congenital disorders, or it could have been surgically removed, or it could have been traumatically dislocated into the vitreous cavity. There are many conditions which can produce aphakic condition, and the aphakia is a high hypermetropic condition, high degree hypermetropia. The hypermetropia without the crystalline lens is up to the tune of around, say, 7 diopters or 8 diopters. Yes, I hope there was some question or there was some query. I think no, there was no query. Fine. So I'll move forward with the next type of hypermetropia. Again, on the basis of clinical presentation, till now we were discussing about the types of hypermetropia or the classification of hypermetropia based on etiology. Now, based on the clinical presentation. Clinical presentations, it could be simple hypermetropia, it could be pathological, or it could be functional. So simple hypermetropia results from normal biological variation in the development of the eyeball. This hypermetropia includes axial and curvatural hypermetropia. This may be hereditary, the condition where the size of the eyeball is small. Any condition where the eyeball size is small leads to simple hypermetropia. What is pathological hypermetropia? Pathological hypermetropia, again, because it results due to congenital or acquired condition of eyeball where the outside the normal biological variations of the development. When the eyeball size is small, in those conditions, the pathological hypermetropia develops. Similarly, what is functional hypermetropia? Functional hypermetropia occurs due to the paralysis of accommodation. When the function of the crystalline lens, the function is accommodation, and the accommodation paralysis can cause hypermetropia. For example, this type of hypermetropia is seen in third nerve palsy or internal ophthalmos. That is oculomotor nerve palsy, and then that can lead to internal ophthalmos. So that internal ophthalmoplegia will lead to functional hypermetropia. So actually there was again MCQ related to the all of the following optical changes occurs in a cataractous lens, which I discussed in the previous session. What are the optical changes happen in a cataractous lens? So usually myopic shift, color shift, hypermetropic shift, and glare. Among these, myopic shift occurs, color shift occurs, even the glare occurs, but hypermetropic shift don't occur in a cataractous lens optical changes. Now, according to the degree of hypermetropia, we classified it as mild, moderate, and severe. So what is mild degree hypermetropia? As I told you before, mild degree means it is up to 2 diopters error, or starting from a very small error of 0.25 diopter to 2 diopters. In this kind of hypermetropia, the symptoms, mainly what a person will feel is asthenopic. Asthenopic symptoms means when the person is feeling stress or eye strain, or there is some amount of ocular headache, or there is a broache while there is a continuous reading. But usually the person will not have any visual symptoms like diminished distance vision or decreased near vision. Usually the symptoms are asthenopic because the visual acuity, the small amount of change in the visual acuity due to mild degree hypermetropia is compensated by accommodation. The accommodation will compensate for the visual acuity. But during the process of compensation, a lot of accommodation is used continuously. That's why there will be asthenopic symptoms. So you have to remember here that very mild hypermetropes, they don't present in clinic with the symptom of diminution of vision. So they don't say us, sir, we don't see distant object, or we are having difficulty in seeing near object. But they say, when I read for a longer duration, that time I feel some broache and suddenly the letters become blur and I will not able to concentrate. I'm not able to concentrate on blackboard, not able to concentrate on textbook, a computer, the laptop. So they come with these type of symptoms and some headache. So that is what is called as moderate degree hypermetropia. Moderate degree means the hypermetropic error is more than 2 diopters. 2 diopters to 5 diopters. That range, if there is a refractive error, in that condition, the main symptom will be difficulty in vision. The vision is decreased. That too, especially the near vision, because for the far vision, accommodation is relaxed and that amount of refractive error gets compensated. But for the near vision, we have to use accommodation, and accommodation is not able to compensate this much amount of refractive error. So the main symptom present, the person present is with the difficulty in the near vision. There will be sudden intermittent blurring, there will be mixing of the letters, or they will have asthenopic symptoms while reading even for a shorter duration. And in severe hypermetropia, it is but obvious when the refractive error is more than plus 5 diopters. Then there will be difficulty in vision also. There will be severe, significant asthenopic symptoms. So that the vision will be decreased for both distance and near. That person is a real symptomatic patient who is having a hypermetropic error of more than 5 diopters. They come immediately to us, to the ophthalmologist, and say that I am unable to see the distant object also, near object also, but whenever I try to see, there will be a lot of pain, blurring, and a lot of complaints, they will come immediately. So these are the patients among all 3 grades which come earlier to the ophthalmologist. What we are talking about. So we have to see what are the normal age variations occur in the refractive status of a human eye. This normal age variation is for a normal human, normal age variation in the refractive status of our eye. At birth, usually as I told you before, we have all of us born, majority of us emmetrope, they born with +2 to +3 diopters refractive error. That is hypermetropic error. But by the age of 5 to 7 years, 90% of these individuals, they shift towards emmetropia. It means that the refractive error of 2 diopters or 3 diopters or 2.5 diopters starts reducing gradually, and by the age of 5 or 6 years of age, the person becomes emmetrope and there will not be any symptom of decreased vision or asthenopic. That person remains emmetropic say up to the age of 50. Now, many students, they get confused. Sir, last time also they asked me, sir, you are telling that the emmetropia remains up to 50 years of age. But when the person is having near vision glasses, that is the age of 40. But here we have to remember that what a person gets near vision glasses at the age of 40 or 42, 43 is called presbyopia. presbyopia is not a refractive error. Just remember, students, presbyopia, many a times, whenever the question of refractive error has been asked as a long question, they write hypermetropia, myopia, astigmatism, and presbyopia. But presbyopia is not a refractive error because it is not produced by the error in refractive status of eye. So it is not a refractive. So emmetropic state otherwise is maintained till the age of 50, 55 years. After 55 years, again there will be shift of towards the hypermetropia. Why? Because the refractive index of the cortical fibers changes compared to the nucleus of the crystalline. That there was a difference between the refractive index of crystalline lens nucleus and crystalline lens cortex. But gradually with the age, the refractive index of nucleus and refractive index of cortex becomes almost homogeneous. So that's how again there will be the refractive power, the total refractive power of crystalline lens decreases with the age, naturally without any formation of cataract. In cataract, there will be hypermetropic shift, myopic shift, but in the normal aging, there will be hypermetropic shift. Because the refractive power of crystalline lens decreases with the age. So again, we can say roughly at the age of 80 years, a person who was a natural emmetrope can have up to 2.5 diopter hypermetropic error or plus 2.5 diopter error. So these are the normal age variations we should know about the hypermetropia. Now we should know something about accommodation. As I told you, that presbyopia thing and hypermetropia get confused a lot of times. Many a times students confuse between hypermetropia and presbyopia. Presbyopia is because of the accommodation. Hypermetropia is because of the refractive error. So in emmetrope, the rays coming out from the retinal point leaves parallel. As we can see here, if suppose there is a point F, the rays which come out are parallel because the refractive status of eye is emmetrope. Whereas in hypermetrope, the rays coming out because the primary focus or the principal focus is behind the retina, the rays coming out are, you can see here, a divergent. Because the rays are divergent, any object situated at any distance will not focus on retina, as in emmetrope. So when accommodation is erased, in emmetrope, any object at infinity or at any distance will form a sharp and clear image on retina. On contrary, in hypermetrope, any object situated at any distance from the eye will not form a sharp and clear image on retina because the rays coming out from the retina is divergent. And divergent rays, they don't meet, they just keep on diverging. So the focal point is always behind the retina. In hypermetrope, to form a clear image, what are the options? Because the image is not forming on retina. So what are options the eye has? Converging power of that optical system has to be increased because the converging power of the system has decreased. So we have to increase it. And how we can increase it? Either by the efforts of the eye or we have to support the eye. What efforts I can put? I can put efforts of accommodation to increase the convergence power of the optical system. So here we have to remember that accommodation is the tool for increasing the converging power of optical system. Or the other option is left that we can artificially support the eye by using convex lens either in practical or contact lens form or by changing corneal curvatures, LASIK surgery. So we have to do artificially. Naturally, it is converging power is increased only by the exercise of accommodation. So this point we have to remember. That's how the accommodation has got a significant influence on hypermetropia. That's why on the basis of actions of accommodation, these hypermetropic elements, various components of a hypermetropic element are again divided. Total hypermetropia, what we see. Most of the time, the question asked is about latent hypermetropia or total hypermetropia or manifest hypermetropia. But our students, they will be writing axial hypermetropia, curvatural hypermetropia. But axial and curvatural hypermetropia are because of the structural errors. Structural errors means either the eyeball is small or the curvature of the eyeball is more flatter. So those are the structural errors. But when the question asked is about manifest hypermetropia or latent hypermetropia or facultative hypermetropia or total hypermetropia, then the accommodation comes into the picture. These elements of hypermetropia are divided on the basis of actions of accommodation, not because of the structural errors in the eyeball. So the question when we ask it should be specifically answered like what I am going to tell in coming slide. Again, there was a question because accommodation we are talking a lot in an adult male. The accommodative power of crystalline lens is what happened. In my previous session of optics, I told you the accommodative power of a newborn, accommodative power of a child, accommodative power of an adult, accommodative power of an 50 years old person. So that's how we have to remember what are the accommodative power of child, adult, and 50 years old. Normal. These slides, these MCQs we will take in further course at the end as per the suggestion. And now we come to the accommodative element of hypermetropia. How the accommodation, action of accommodation influences the hypermetropia and the errors are produced. So what is total hypermetropia? Total hypermetropia has got two components. The first component is latent hypermetropia and the second component is manifest hypermetropia. As we suggest these are names, we can understand what they mean. Latent means hidden. Latent means hidden. Something is hidden, which is not seen from the outside. That becomes latent. Manifest. Manifest means visible, which is showing itself. So there are two parts of total hypermetropia as per the role of accommodation. One is latent, one is manifest. Means one is hidden, one is showing it. Again, in manifest hypermetropia, there are two types, which is facultative hypermetropia and absolute hypermetropia. These again are name suggest. Absolute means it is confirmed, absolute. And facultative means yes, it can be compromised with some mechanism. So what is latent hypermetropia? As I told you, hidden. It is corrected simply by the physiological correction of ciliary muscle tone. Here we have to understand the difference between the tone of the ciliary muscle and the power of accommodation. In accommodation, there will be change of the curvature of crystalline lenses. That will take separate session of accommodation. And ciliary muscle tone is a normal tone like any other skeletal muscle has. So this simple latent hypermetropia is compensated and corrected by the physiological tone of ciliary muscle. That's why it is usually hidden. And as a rule, this hypermetropia is maximum up to 1 diopter. And that's why this can be revealed because it is hidden. It can be revealed only we use atropine cycloplegia to abolish the tone of ciliary. Then only we can detect this hypermetropic error. As the name suggests, manifest is showing us it has got two components. Facultative is that part of manifest hypermetropia which can be corrected by the efforts of accommodation. Now here the difference between facultative and latent. Latent is ciliary tone, facultative is accommodation. So these two are entirely different. So facultative can be compensated, If facultative hypermetropia is too much, then even accommodation may not compensate it. Or accommodation is reduced, then also the facultative hypermetropia is not compensated. It will become manifest. And absolute hypermetropia is the which part of manifest which cannot be corrected by accommodation. So absolute hypermetropia will show its symptoms of either decreased vision or astigmatism. Just for a rough calculation between the absolute hypermetropia and visual acuity, well, how much absolute hypermetropia can decrease how much visual acuity. Usually 0.5 diopter will give 6.9. That is almost normal. Person will see almost normal and remains minimum asthenopic symptomatic, but visual acuity is somewhat okay. They will say, no, you don't have much problem. But when the absolute hypermetropia becomes, say, 1.5 diopters, this 1.5 diopters, then the visual acuity comes to 624. So almost 3 lines are lost. So the person will be able to see only the larger font. In that case, when the absolute hypermetropia is plus 5 diopters here or more, as we can see, if it becomes 4.5, the visual acuity remains only 3/60. So that is roughly 30% of a normal visual acuity. So we have to understand that these are rough comparisons. These are just approximate comparisons. Like at how much absolute hypermetropia, what will be the visual acuity of the person. Now let us come to the symptoms of hypermetropia. As I told you, the main symptom of hypermetropia is astigmatism or eye strain or ocular strain or frontal headache. There are so many parallel or synchronous terms for this symptom, which is most commonly seen in all types of hypermetropia. It could be simple, it could be pathological, it could be moderate degree, or it could be curvatural, or it could be axial, or it could be total, or it could be absolute hypermetropia. In these all whatever types of hypermetropia, the most common symptom remains astigmatism. There could be headache with blurring of vision. Why I am detailing these many symptoms? Students, they used to ask me in my lectures also, even in the visual lectures also, and the physical imaging lecture. Sir, you explain about these symptoms because when I checked the paper, I have seen all symptoms has been written like cocktail of myopia, hypermetropia, everything is mixed up. Students, but the examiner want to see only the specific types of symptoms. Examiner don't want to see that the person is unable to see the distant object, which is the most common symptom of myopia without headache, without asthenopia. Myopics, they don't have any symptom except diminished distance visual acuity. So, and that is the least common symptom of hypermetropia. Most common of myopia, but least common of hypermetropia. And that will be the first symptom I see in the answer sheets of students. So that's why I go with the most common presentation, clinical presentation. So the most common clinical presentation of hypermetropic person of a child or say around 15, 16 years old person is astigmatism, eye strain, ocular headache, frontal headache, brow pain. They will be doing all brows and because there will be difficulty blurring of vision. They will see, but they will see blurring, blurred objects. There will be intermittent sudden onset of blurring. Like the person is reading a book and suddenly all the letters they mix up. There could be convergent strain because most of the time to see the near object clearly, they have to use excessive accommodation. And excessive accommodation and convergence, they are both go hand in hand. Always. Whenever there is accommodation, there is a convergence. Convergence of eyes. Whenever there is convergence, there has to be accommodation. So both of them are fulfilling each other. So always they are together. So when excessive accommodation is used, the eyes become more convergent. So there will be called cross. There could be early onset of presbyopia. Why? Because over a period of time, that person is compensating the distant vision and the near vision with the help of accommodation. You have already spent your bank account. So that is already the accommodation has been spent. Because the accommodation has been spent, to see the distance and near object clear over a period of time, the account is empty. Because the account is empty, that person develops presbyopic symptoms at an early age. Usually presbyopia starts after 40 years of age. Because the accommodation after 40 years of age reduces to 2 to 3 diopters. But in cases of hypermetrope, their account is empty. Because their account is empty, so they see this presbyopic symptom earlier age, younger age. If suppose we keep these hypermetropes uncorrected, what will happen? In case of myopes, what will happen? That we'll see further with the myopes. But for the hypermetropes, if they remain uncorrected, they can develop recurrent eyelid problems like blepharitis. Blepharitis is lid inflammation, lid margin, stye, that is external ardiolum, or chalazion, that is internal ardiolum. These are basically, chalazion is infection of gland of Jain, and the stye. So meibomian gland inflammation is internal ardiolum or chalazion, which becomes later on, and stye is the infections of gland of Jain. Similarly, blepharitis is the root margin, eyelash margin, there will be inflammation. It could be ulcerative, it could be squamous. Why these kind of eyelid problems happen in uncorrected hypermetropes? Because majority of time to see the near object, they have to focus hard. So during hard focusing, they rub their eyes constantly because there is suddenly blurring of the near object. They will rub their eyes and they will again start focusing. They will again rub eyes, they will again start focusing. So this continuous intermittent rubbing will bring the infections from their fingers and hand to the eyelid margin. So these infections get transmitted and that person will develop these kind of problems. Some young children who are of high hypermetrope, high degree or moderate degree hypermetropia, if they remain uncorrected, no glasses has been given, no correction has been given, in that case, those children can develop amblyopia. Amblyopia is a serious condition because once the amblyopia sets in, then it is almost like very, very, very difficult to correct the amblyopia. The visual acuity, amount of visual acuity lost because of amblyopia remains constant. So children who are moderate degree or high degree hypermetrope should be detected earlier and they should be corrected. That error should be corrected so that the amblyopia won't set in young children. In very young children, around say 2 to 3 years of age, when they start using a lot of accommodation, as I told you before, accommodation convergence hand in hand. So excessive use of accommodation will produce accommodative convergent squint or establishment. So accommodative convergent squint has to be corrected at an early age with glasses. And this squint, if not corrected, will lead to amblyopia in later stages, and that squint remains constant. So young children, again with moderate to high degree hypermetrope, should be detected and corrected. Similarly, mild or moderate degree hypermetrope, if not corrected, they may develop primary angle closure glaucoma because most of them, as I told you in the first slide, the most common presentation of refractive error is hypermetropia, and in that it is axial hypermetropia, where the eyeball is short. Because the eyeball is short, the angles are also narrow, occludable. Those narrow or occludable angles, in those kind of patients, even slight change in the productions or the drainage of the aqueous can lead to angle closure block. How to treat? How to treat the hypermetropia? There are two methods. We can treat them by optical correction, as I told you, and second, we can do is surgical correction. So optical correction, we can use glasses, spectacles, convex lenses. In spectacles, we can use contact lenses also. This convex lens, as I told you, can be used with spectacles or in the form of contact lens, or there could be surgical changes in the curvature of cornea. or these contact lenses can be implanted inside if their degree of hypermetropia is very high. So, but the most common treatment is optical, and that too is spectacle. Here we have to remember, while we are dealing with the spectacle corrections of the hypermetropia, if there is that person of hypermetropia is having exophoria. Exo means outside. When there is deviation of the eyeball outside, outward, is called exophoria. That exophoria is there. In that case, the refractive error correction in hypermetrope should be undercorrected. What do you mean by undercorrection? Undercorrection means if suppose the refractive error of that person is full refractive error is 4 diopters plus 4 spherical or plus 4 diopters. In those cases, the glasses what we give prescribed to that person should be slightly undercorrected, say around 3.5 or plus 3.25. So we have to little undercorrect if that person is having exophoria. Suppose that person is having esophoria. Esophoria means lot of convergence is used to compensate the hypermetropia. In those cases, the correction should be full. Means plus 4 diopter percent should be given plus 4 diopter. Here the most important point, which we should take home message, kind, is that hypermetropia do not correct, overcorrect. Like means plus 4 diopter hypermetropic should not be given plus 4.5 or 5. If you give hypermetropic overcorrections, there will be lot of asthenopic symptoms and the convergence, accommodative convergence is again conjugated. So hypermetropic are never overcorrected. Either they are undercorrected or we are fully corrected. Optical wise. And the next modality of treatment of hypermetropia is surgical. Surgery, we can do hyperopic LASIK. We can do photorefractive keratectomy. We can do conductive keratoplasty. We can do thermal laser keratoplasty. We can do refractive lens exchange. And we can do phakic intraocular lenses. So these surgical procedures, in case of correction, when I take, we will go in detail if you want, but usually for an undergraduate, what I feel is that if they write in the treatment part of a hypermetropic question, that there are two types of treatment, one is optical, one is surgical, and optically we can do spectacle, contact lenses, and we should not we should undercorrect for exophoria and fully correct for the esophoria. And in surgical procedure, if they write these names, like I have written here, like hyperopic LASIK, keratectomy, conductive keratoplasty, I think that much is enough. But in case if you want, I can go for what are the steps of hyperopic LASIK, how we perform this photorefractive keratectomy, what is conductive keratoplasty, what are the instruments used, what are the procedures, and what is thermal laser keratoplasty. Refractive lens exchange is simple. Here we remove the normal crystalline lens and put a higher power of intraocular lens, and that's how the power of the eye has been increased. Phakic intraocular lenses are again implantable contact lenses, where this contact lens is inserted just above the normal crystalline. But conductive keratoplasty is a procedure which uses various wavelength, thermal wavelength. Thermal laser keratoplasty is again a laser procedure. LASIK is a laser procedure. Photorefractive keratectomy is a laser procedure. So if you want, I can go for the detail. But for undergraduate level, when the main question of our hypermetrope has been asked, they expect in your exam to be written what is hypermetropia, definition of hypermetropia. In that, majority of the students, they forget to write accommodation at rest. Most of them, they write that when all the rays coming from infinity or all the rays, the parallel rays are not focusing on retina, they focus behind the retina. That much, I think 99% students write. But some majority of the students, they forget to write another additional line when accommodation is at rest. So that point has to be included in the definition of accommodation, and even in my. Second thing is classification. After that, there will be classification. Classification, we should write in detail, as I told. Then there will be accommodation. You have to write about accommodation and latent total hypermetropia, latent hypermetropia, and manifest hypermetropia. Then you have to write the symptoms. Then there will be investigation. Actually, they expect there's a management part. They do expect investigation. But most of the refractive error, you need not to write for all those hemograms and those CT scan or B scan of the eye and all. No need. And we'll go for the treatment part. Treatment, you have to write optical and surgery. So I think if you write this hypermetropic question like this, even a full strength hypermetropic question can be completed. And if they ask a part, short note like latent hypermetropia or manifest hypermetropia or classification of hypermetropia, or just they will ask treatment of hypermetropia, those questions can be answered easily by undergraduate students. Next, we can go for myopia, but I think that will be too lengthy in a single stretch. If I go for hypermetropia and myopia both, then it becomes too much confusing because majority of the things are different in myopia as compared to hypermetropia. Hypermetropia is more theoretical, but it is the most common presentation, as I told you, axial. Most of the newborns born with a refractive error of +2 to +3 diopters. So in the next session, in the coming session, I will try to cover the myopia, because myopia many a times question has been asked mainly on myopia. Hypermetropia, most of the time, most of the universities, they ask only the short. So I think we will complete the session, today's session, and I invite for all the questions. If any of our students have any questions, they can ask. I think Balaji sir, we will take the myopia session in coming session. Myopia is a little large topic. So I think, sir, we'll go ahead with the questions. Or you want me to show the MCQs and discuss those MCQs?
Yes, sir. You can please show the MCQ, sir.
Okay, I'll go for the MCQs.
Thank you, sir.
Okay, so let us start. These MCQ basically I framed from my previous session. Optics, normal optics of the human eye. There was no error. So the MCQ for students is that like these are all MCQ framed. It's not there in your routine Bhatia or your PG coaching classes. So this is the MCQ for remembrance also, and they can be asked also. In an adult, according to listings reduced eye, in the last session I explained about listings eye, Donder's eye, and Donder's simplified eye, listings reduced eye, and Gulstan schematic eye. So in listing reduced eye, the anterior posterior axial length of the eyeball was 22.4, 23.4, 24.4, or 25.4 millimeters. So can any of my students can tell what is the anterior posterior axial length has been explained or shown by listing reduced eye? I think the students are connected to me, or Any of our panelists can say, can give an idea.
We will move on to the next MCQ, sir.
Okay.
They will get it
Actually, it was given
later
was
on.
24.4. The listing reduced I, then to posterior axial length given to the eyeball was 24.4. The next MCQ is again on the radius of curvature of crystalline lens in a normal human arm. Anterior 9 mm, posterior 6 mm, anterior 10 mm, posterior 6 mm, anterior 10 mm and posterior 7 mm, or anterior 9 mm and posterior 7 mm. Lens again two curvature, anterior and posterior. So normal crystalline lens has got an anterior curvature of 10 mm and a posterior curvature of 6 mm. This is just for the revision of the optics. Similarly, the next MCQ, as I discussed before, what is the normal optical change? Cataract lens, there could be so many changes, but optical change is myopic shift, color shift, hypermetropic shift, or glare. It is basically hypermetropic shift don't occur in a cataract change. It happens in an aging lens. This MCQ, what is the normal adult male accommodative power of crystalline lens? As I told you, in a person born with 12 to 14 or 14, 15 diopters of hypermetropia, usually accommodative power, and in a normal adult, the power reduces to 6 to 8 diopters, accommodative power. Reduces to 6 to 8 diopters. And at the age of 40, it becomes 2 to 3 diopters. That's why we have to use near glasses to see the near object. That's all. These 3-4 MCQs were there. Thank you. Thank you for the session.
Thank you, sir. Thank you for the wonderful session, sir.
Thank
and
you.
it is
Welcome.
most informative too. Thank you, sir.
Yeah, when we'll go for myopia, I think when we join the students, then we'll go for more MCQs and more interaction. Even I can show some good images also, because I have myopia. We have a lot of images, so I can show some images also.
Okay, sir.
Fine. Thank you. Thanks for that.
Thank you. Thank you, sir. Dear viewers, thank you all. You still have some interesting sessions upcoming today. Topic is Salmonella infections by Dr. Ajit Vijayan. And tomorrow's session, we have Dr. Swaminathan presenting pathology and Dr. Madangi handling hypothalamus topic from physiology, and Dr. Nandita to take abnormal development topic. Thank you all and see you again.